Good evening, and thank you for joining one Welbeck case-based heart rhythm update. I'm Dr. Melanie Mountain. I'm a GP working at King's College Health Centre in London. We're joined this evening by two of the UK's leading cardiologists. Professor Richard Schilling is Professor of Cardiology at Barts Heart Centre and President of the British Heart Rhythm Society. Dr. Boon is a highly experienced consultant cardiologist and electrophysiologist. Boon is considered one of the best cardiologists in London. He's a clinical lead for the nationally renowned Imperial Syncope Diagnostic Service based at Hammersmith Hospital in London. You might recognise him because he actually appeared on Diagnosis Detective last night on BBC. Both cardiologists practice privately from One Welbeck, a brand new multi-patient, multi-specialty day case facility in the heart of London. The webinar is going to be divided into three sections. The first section will be about palpitations. The second section is going to be about dizzy spells and loss of consciousness. And the final section covers the atrial fibrillation and the three-point plan. Before I hand over to Richard and Boon, we encourage you to submit any questions that you might have in the Q&A tab at the bottom of your screen. These will be answered in an interactive session at the end of the webinar. Without further ado, I'd like to hand you over to Professor Richard Schilling to talk about palpitations.
Thank you very much, Melanie. We got a message from some of the audience that the sound wasn't clear. I hope that that's now sounding a bit better for everyone. So this is our agenda tonight, and we've tried to make sure that we're going to be talking around cases that you, our friends and colleagues in primary care, have sent to us. And we're going to try and focus on an angle as to how you might manage this in primary care, or how we manage the patients when we first see them coming in. So the first case that we were sent was a 32-year-old female who presents with palpitation. There's a family history of ischemic heart disease, with her father dying in his 50s of myocardial infarction. But the patient themselves had no past medical history, no history of taking any medications. She drinks about 4 to 5 cups of coffee and tea per day, a glass of wine per day, and she's overweight. I would imagine that this is a clinical scenario that presents to GPs every single day. And the challenge is, how do you know who's got benign problems, and how do you know who's got a serious problem or potentially serious problem that needs further investigation? So for me, when I'm talking to these patients, there is the first step is to exclude a red flag history. And the three things that are raising alarm bells or raising red flags for me is someone with unexplained blackout. And by that, I mean someone that describes, I was sitting at dinner, suddenly I wake up with my face in the food. And that's in stark contrast to someone who says, oh, I got up in the middle of the night to go to the toilet, I was standing up, I felt cold and sweaty, and then I collapsed and fainted. So that is a vasovagal episode, whereas the unexplained blackout has no preceding symptoms and nothing to warn the patient that something bad is going to happen. So that's a red flag. The second red flag is the patient having a history of some form of structural heart disease, previous heart attack, operations, or congenital heart disease. Then palpitations always warrants at least some careful consideration. And then the third red flag is a family history of unexplained sudden death, because they may have a very rare inherited arrhythmia syndrome. And so asking about the family history in first degree relatives is a very important step. And the things that stand out in the family history are young, below their 40s, first degree family members dropping dead suddenly without any warning. The step two, then, if you've got rid of the red flag symptoms and signs, then you're pretty certain that the diagnosis is likely to be benign. And so your next task is to use the history to try and identify what the diagnosis is. And by far the most common diagnosis is skip beats or ectopic beats. And the patient will describe their heart skipping or missing a beat, followed by a very strong beat, which is an ectopic beat. And what happens is when you get an ectopic beat, the extra beat comes in early, the heart compensates for that by putting in a post-ectopic pause, which gives it more time to fill with blood, so that the overall rate and the overall heart output are the same over the course of the 3 beats. And it's that compensation that gives the patient their symptoms. I will normally say to the patient, I get these all the time, which I do. I'll explain that they're not prognostic or significant in any way. And often they're asymptomatic, but they can flare up for a few weeks and cause annoying symptoms and then disappear for no obvious reason, and they don't need any treatment. That's differentiated from a sustained and regular palpitation, which is usually associated with some form of benign supraventricular tachycardia that the patient may have been born with an extra connection in the heart, that only warrants investigation because it can often be treated very successfully. And then the third story that you want to look for is sustained and irregular palpitations, which may be resulting from atrial fibrillation, which obviously would be very unusual in this patient's age group. The third step is, once you have an idea of what the diagnosis is, you then want to confirm it. And for benign ectopic beats, usually nothing else is needed, just reassurance. An ECG can be helpful because if it's normal, then it's really unlikely that the patient's got structural heart disease or rare inherited arrhythmia syndromes. So the ECG is a very rare, easy and simple test. And then if you want to be really safe, then you could do an echo to show that the heart is structurally and functionally normal. Now notice that I don't mention Holter monitoring at all. The bane of our lives as EP doctors is Holter monitors, because they really have no prognostic value at all. It is extremely rare that they're useful because it's unusual for the patient to get symptoms every 24 hours. And so the 24-hour tape is usually going to be completely useless. So I wouldn't advocate the use of Holter monitoring in this scenario. Step 4 is confirm the diagnosis, and this is aimed at planning treatment or reassuring the patient. And here, the idea is to try and record an ECG during symptoms. And that, of course, depends on the severity and the frequency of the symptoms. So if a patient's getting symptoms several times a week, then doing a 7-day ECG monitor may give you a pretty good chance of recording an ECG during the symptoms. If, however, it's less frequent, then an event recorder can be helpful, or an implantable loop recorder. So I think Boon's going to talk about event recorders in a little while, but essentially patients can buy their own event recorder. The Cardiologist is a good example, and it turns their phone into an ECG machine so that they can record an ECG during their symptoms. For patients that get more dramatic symptoms, here's the Cardiologist or the Alive course stuck on the back of a smartphone, and you can see that if they get symptoms, they can just open up the app and record it. The implantable loop recorder is an injectable device that sits under the skin. It lasts for 2 years and it records the ECG on a loop. And that's really useful for patients that have infrequent but dramatic symptoms where they don't have time to get the app out and turn on the Cardiologist. So the loop recorder will record it automatically for them. So for this first bit of palpitations, thinking about case 1, it turned out that this lady has salvos of palpitations lasting a few seconds several times every day. They were reassured that this is ectopic beats, they don't need to be worried, but they needed reassurance. So they went on to have an ECG, which was normal. They then went on to have an echocardiogram, which was also normal, and a thyroid function test to make sure that they weren't hypothyroid. In the end, they had a Holter monitor, which frankly didn't add anything to the management because it didn't change anything we would do, but it confirmed that they were getting benign salvos of atrial ectopics during these palpitations. In the COVID area, I'm seeing a lot of patients that seem to be getting these post-viral that then settles down, but very often they have no obvious triggering factors, and you've just got to reassure the patients, and after a few weeks or months, they will often disappear. Things that can help the patient The most important is weight loss, so that can have an impact on ectopic beats. Drinking alcohol in moderation, and they're very often advised to reduce caffeine, but for many patients that makes no difference to them at all. So I tell them, look, if you're going to do one thing, lose some weight, and another thing, drop your alcohol, but drink as much coffee as you want. So that's the end of that section. Melanie, did you want to ask questions, or are we going to go on to Boon and his bit?
I think at this stage, move on to Boon and we'll come back to the questions at the end. But many thanks to everyone for starting to submit the questions. That's going to be really great for the interactive bit later on.
Boon, remember to unmute yourself before you start.
Can you hear me now? Perfect. Can you hear me? So,
Very well.
good. So I was going to kick off with a case of a 34-year-old male with syncope. So this is a Filipino nurse who's had multiple lifetime episodes of collapses with a tendency to hit rushes while standing up quickly, with typical prodromal symptoms of sweatiness, shortness of breath, palpitations, and nausea, typically provoked by warm environments, prolonged standing. On this occasion, he had a tooth abscess with a fever of 38.6, and he was admitted with extreme dizziness, with nausea, sweatiness, and lightheadedness. And I guess the reason I've highlighted the history like this in green is when I take a history, have a traffic light system in my head, and with all the features that are what's considered benign, I tend to place a label and say that's green. You can see here in amber, I've got the word palpitations, because what I'm trying to look for are the features in the history that would mark this patient as high risk. And I guess in your stepwise management of assessment and risk stratification of syncope, step one should be, very importantly, excluding the red flags. Now, red flags in syncope include unheralded syncope, syncope with injury, syncope during exercise. So syncope during exercise is one that I would always ask for clarification, because there is a particular form of vasovagal or situational syncope that can be said to occur with exercise, but on clinical history taking can sometimes be ascertained to be occurring in the rest stage following exercise. So it's a very different history when your patient is jogging and in mid-run collapses without knowing how he got to the floor and smashed his face, compared to the patient who's playing a football game and on a five-a-side match got to half-time, walking to the bench and took a swig of water and then collapsed to the floor. Those two elements of history, or those two types of history, are very, very different in terms of the prognostic and the risk stratification, because the exercise syncope that is a red flag is one that occurs in the midst of exercise or whilst ramping up exercise, not during the warm down. Similarly, syncope with injury can occur with vasovagal syncope, but this is quite uncommon. Most patients with syncope have sufficient prodrome and warning symptoms to take the relevant evasive action to avoid injury. The fact that they cannot avoid injury, even with vasovagal syncope, already puts them at an intermediate risk stage, because some patients with vasovagal syncope can have very short prodromes, and these patients often need more aggressive management that we can talk about in a short while. Relevant to the case that I'm discussing is syncope with preceding rapid palpitations. And the question for this chap that I presented with the palpitations here highlighted in amber is what the nature of the palpitations were. Any syncope with past history of ischemic heart disease and MI or heart failure should be considered a red flag, and then an abnormal ECG should also be considered a red flag. So after excluding the red flag, the basic assessment of syncope is history, history, and history. And in terms of the history, the questions I would ask the patient in a very short time span that you have with your patients is when they're trying to tell you about what happened after they woke up and what the paramedics did for them and what their oxygen sats were when they were being carted off the ambulance, you stop them and you say, tell me what you were feeling in the 30 seconds before you lost consciousness. And they, in my experience, will often always want to tell you and embellish you with the most relevant things in their viewpoint, but stay the course. Understand what happened in the 30 seconds before. And if you ask a question like that, you'll often pick up the red flag symptoms here. Beyond that, I normally step back and ask them what they were doing on the morning of or the day of syncope or the night before syncope, because this often gives a clue. With vasovagal syncope, there are often prodromal symptoms that if we don't dig down and do some detective work to try and understand what were the constellation of situational factors that came together that provoke syncope, we might not find out, because the patient is very keen to tell you about what happened after the event. So they might, for example, have started the first day of their job or been out late, working hard over a few days or weeks and had a late night sleep, woke up late, skipped breakfast, and was in a long meeting all day. And then on the way home, stopped by to exercise in the gym. And then whilst having dinner and after dinner, felt lightheaded and then lost consciousness. These features are all very relevant to a diagnosis of syncope. Now, once you've established that that you've got all the kind of major factors that would give you an inkling of the diagnosis, the assessment of syncope is completed with an ECG and ideally a lying and standing blood pressure taken at least with 3 minutes of standing upright with the legs straight, hands by side without fidgeting. And just with this simple assessment, we can typically identify the cause of syncope in 80% of patients and not need to have an onward referral because the diagnosis is clear. And majority of this diagnosis is going to be vasovagal syncope. Now, on this particular patient, the lying blood pressure was 115/80 with a heart rate of 75. And the standing blood pressure dropped by 20 mils of mercury with a heart rate accelerating associated with a head rush at the time that he was examined. And so the diagnosis here is very clearly vasovagal syncope. And if we talk about the management of vasovagal syncope, this is something that should be suggested to all patients with the conservative strategies started first. So hydration, aiming for 2.5 to 3 liters. Salt, if the blood pressure is normal or low normal. And what some patients who find it very difficult to take salt that I recommend is something like NUN, N-U-U-N, or ORS. These are isotonic tablets that look like, that are like the vitamin C effervescent drops that you can put in a glass of water that fizzes. And that's quite nice tasting and particularly good pre-exercise. Isometric exercises, taking early evasive action. And then I'll spend a bit of time talking about the education of the pathophysiology of syncope, and then rarely talk about the need for prescription with blood pressure augmenting drugs with slow sodium, midodrine, and fludrocortisone. And if I could just kind of very quickly digress for 2 minutes, because there is a resource that I often use several times in each clinic for my syncope patients. And this is something that we created to explain with a very nice diagram for the patients why patients might experience palpitations during syncope, why they might get chest pain or shortness of breath prior to syncope. Because one of the major reasons I get patients in my tertiary syncope clinic is because GPs and our tertiary cardiologists feel that the prodromal symptoms before vasovagal syncope are very difficult to explain. So with this diagram, I just bring it up, I turn my iPad across on my screen, and I get to this page, which is Why Do I Faint on stopfainting.com. I click on see how it happens, and I explain to the patient that the blood pressure at rest will fall slightly as we stand up. And if I click on this button again, next step, unwell, lightheaded, and I toggle the face, what I then demonstrate to the patient here is I demonstrate this drop or reduction in blood pulled by gravity to the lower limbs. And I talk about this exactly. So you're hearing my spiel to the patients. And when this happens, the blood pressure falls from the normal range to the amber range, something like 90 systolic, which is what our patient felt when he felt this hit rush. And the hit rush can be explained by less blood circulating into the brain because all the blood is being pulled down with gravity. But what is interesting and will be very reassuring for your patients is that when the heart is empty and it beats a lesser stroke volume, what happens is that the carotid baroreceptors send a signal because it's not so stretchy anymore, and it sends a signal to activate something which is the fight or flight response. And it's this fight or flight response that drives two things. One, vasoconstriction. And this vasoconstriction will immediately, within, I would say, 5 to 7 seconds, cause the blood vessels in the lower limbs to constrict to return blood to the heart. But secondly, it promotes cardiac chronotropy. And this increases the heart rate because, of course, stroke volume times heart rate equals cardiac output. So it maintains your cardiac output. And this is the reason patients with vasovagal syncope in the pre-syncopal phase develop palpitations. There is something else that adrenaline does in this fight or flight activation, and that's cardiac inotropy. And cardiac inotropy is the concept that your heart is beating stronger, demanding more oxygen, and that can give you the sense of chest discomfort akin to angina. Some of you might have heard of POTS, or postural orthostatic tachycardia syndrome, and one of the major difficulties with these young patients who don't have any coronary artery disease is a very typical chest pain that they do describe. So this is cardiac inotropy combined with chronotropy that's causing the constellation of symptoms. And oftentimes, in just being able to describe to them with the aid of this diagram that all their symptoms make sense and that you're not dismissing them is enough and sufficient to reassure them that you know what you're talking about. You enhance their compliance to increase the hydration and the salt, and then allow them to understand the physiology and be reassured by your great understanding about why they're experiencing those pre-syncopal symptoms. Now, just one word of caution. If this man, for example, changed his history and on mobilizing to the toilet in the evening, he had a sudden collapse with facial injury after taking 3 steps, this immediately in my mind makes it a red flag symptom. And I'd want to know, for example, from a witness or from a corroborative history, what exactly happened. And if, for example, the ECG shows this, then this concave ST right bundle branch in V1 with the ST elevation makes the diagnosis of Brugada syndrome. So we shouldn't forget that the ECG forms part of the syncope diagnosis. And with that, I guess I will either take questions or push back to Richard.
I will cut it. Can you hear me okay?
Yes,
Okay. I will actually then, I think, cut in to make it a bit interactive now, because you had some great questions coming in, actually. I think this would be a good point to ask Boon. Patients have been asking about, attendees have been asking about patients with wearables. You mentioned a live core, but I think it'd be interesting to also understand how accurate you think the portable watches, the Apple Watch, and those devices are, and what value you think they bring.
So I quite like the Alive Core. It's a cheap technology costing the patients £100. It couples to most of the available modern handsets, and in a downloadable, it provides a downloadable PDF. But I just want to demonstrate to you, if you can see my screen here. I don't know, Rupal, if you can make mine the main screen. This is an Apple Watch, and when you get your patients to get a watch, tell them to get it somewhere, either in the UK or US, or somewhere which can activate the ECG device, because it's very interesting how Apple have banned the ECG device from other countries. For example, Dubai. If you buy an Apple Watch in Dubai, you won't get this function. And on this function, there's an EKG. I'm just going to record the EKG, which will show a sinus tachycardia, I'm sure, as I'm speaking. And just in, and Richard might say VT with the bundle branch block, but in just 30 seconds, if I just slow my breathing down, it will, that's not what it's meant to show. So it's inconclusive there, but patients can often get a recording which says sinus rhythm, and this is downloadable. And what I would say more than just the sinus rhythm is if they show me this ECG, and I was checking with Richard before as well, I believe it. I believe this Apple Watch data. It's good enough to show me a PQRS T wave. I use it mainly for arrhythmia to detect atrial fibrillation. And the algorithms on the Alive Core and the Apple Watch are generally good enough to detect a diagnosis of atrial fibrillation. Everything else it will call inconclusive. Now, here I'm talking as I'm doing this, and so it's called it inconclusive twice. I'm not going to do it a third time, but I have seen and diagnosed patients with isolated ventricular ectopics with the post-compensatory pause in clinic as they were experiencing their ectopic beats live, and that allowed me not to even take any step further with a Holter. I discharged them there and then and reassured them with their own watch about the diagnosis. So I believe in it, and I think it gives you clarity of data. I wonder what Richard's thoughts are.
I think you said it all, Boon. I don't have anything to add. Let's go on to the next question, because there's some great questions coming in.
Yeah, there are some great questions. Okay, thank you, Boon. That was very helpful. I think I'm actually then going to go back to a question, I think, for Richard regarding palpitations. And I think it links into this question about devices, because the question is, for exercise-induced palpitations, how can you differentiate sinus tachycardia from a sort of more serious pathology?
Okay, well, that's a great question, and it's all to do with the physiology. So sinus tachycardia is a response to adrenaline, and because it's a hormonal response, the rate will accelerate over a period of time. And so the patients may not be terribly good at describing it, but they'll often describe the heart rate climbing. It's 100, and then it goes to 110, then it goes to 130. Whereas a pathological tachycardia, and bear in mind that almost all pathological tachycardia is benign, is usually due to some form of short circuit or re-entry, which will switch on and off. And so the difference is that the rate will suddenly change from one to the other. So the patient will classically describe a sudden onset regular tachycardia. When it stops, they may describe it stopping gradually, because of course by then they've got lots of adrenaline on board. And even when the rhythm stops, they may find that it slows down gradually because they then switch to sinus tachycardia, which is a similar rate. But the clue is in the sudden change in rate as opposed to the gradual. And I say to them, look, it's the heart responding to something rather than the cause of something if it's a gradual acceleration.
That's great. That's extremely useful on a grassroots, seeing the patient level. Thank you. We'll do one more question about palpitations before we move on to the next section. One of the GPs has highlighted that when we were talking about palpitations in young people without red flag symptoms, there were still quite a few investigations that you suggested doing, whereas of course GPs often have to try to make these diagnoses without a lot of investigations readily available. And I guess the question really is how appropriate it is to make the diagnosis that it's a benign palpitation without doing a lot of investigations.
Well, I was so upset and fired up by that question that I actually wrote an answer as well, because I completely agree with the questioner. Very often, by the time the patient comes to us, they've already had these tests, which is very frustrating. If I use advice and guidance, which I now find really helpful in communicating with GPs, I'll often advocate that they don't do anything. And I made the point in my written answer that GPs are the unsung heroes in stopping the hospitals being overwhelmed by patients that have completely normal phenomena. So I would agree with that questioner that I wouldn't do any investigations if the story is typical of ectopic beats. It's just that that's what happened in that particular case.
Great, that's very helpful and reassuring to know. I think, should we move on to the next section and then come back to some of the questions coming in?
Great, so we're going to go on to the third section, which is atrial fibrillation. This was an interesting question of a 51-year-old man who had an incidental finding of AF at their medical. They'd been asymptomatic, they had no other risk factors, and they were referred for a cardioversion, but this was delayed for 3 to 4 months due to COVID. And they've now had the cardioversion and remain in sinus rhythm. And the question was, what's their risk of recurrence? What are the appropriate preventative strategies? And what are the indications for treatments? And can we give a refresher on assessing thrombotic risk? So the first question that patients will ask me is, why have I got the AF? And I will say to them, look, there aren't any causes. There are factors that make it more likely to happen. And many of the factors are out of your control. And I list 3 of them in the top there in blue. So it's a design flaw of the mammalian heart. Racehorses get a lot of atrial fibrillation. There is a subtle genetic element, so it can run in families, but it's not strong. And if you've got AF, don't worry that your kids are going to get it. And age is an important factor. And frankly, if we all get old enough, we're all likely to have AF. It's 10% of people over the age of 70 have AF. Weight appears to be the single most important risk factor. And that's not just for AF, but also ectopic beats. We were asked a question earlier on about this. There's a study out of a group in Adelaide that was really impressive, where they took patients who lost weight and that reduced their AF burden by something like 50%. And that seems to be more important than alcohol, which is still an important factor. And I will normally recommend patients drink less than 15 units a week if they want to avoid AF. And being fit, so exercising is good for AF, it shouldn't be avoided. There's no evidence that caffeine has an impact. So while some patients will swear blind that it is prompted by caffeine, for most, caffeine avoidance makes absolutely no difference to their symptoms. So I would argue that in this case, in the absence of modifiable or treatable causes, frankly, recurrence is almost inevitable because the patient's 51, they're going to live hopefully for another 30 years. It seems implausible that they won't develop AF at some point in the future. So what about prevention of stroke? Well, we all know that the CHADS-VAS scoring system is the scoring system that's recommended in the current NICE guidelines, and it's really nice and simple. The important thing to emphasize to patients is that AF isn't the cause of stroke. AF is an association with stroke, and an important association if it's also linked to some of these other risk factors. And the reason I emphasize that is because patients would be terrified if they go into AF thinking, I'm going to have a stroke. The good news is they're just as likely to have stroke when they're in sinus rhythm as when they're in AF. So don't be panicky just because you're in AF. It's having a diagnosis of AF and one of these other risk factors. And actually, the risk climbs quite profoundly as your CHADS-VAS score goes up. So the CHADS score is pretty much your risk of, your percentage risk of stroke per year. I'm sorry, there's a dollar sign here. This isn't because it's a private facility. I think that's a typo. It should read percentage. If you've got a CHADS-VAS score of 2, your annual risk of stroke is about 2%, which means that if you're going to live 10 years, you've got a 20% risk of stroke over that 10 years. So a really good reason to have stroke prevention. The key simple things is that I don't use has-bled. While it's advocated in risk scoring systems, frankly, all of the has-bled scoring factors are also CHADS-VAS factors. So I don't bother with assessing their bleeding risk other than to remove those things that are obvious, like poor control of warfarin, lots of alcohol. So I don't bother with that. I just use common sense. And if they have a CHADS-VAS score of higher than 1, I would really encourage them and say, look, if it was me, I'd take it. Direct oral anticoagulants or NOACs, I would use as my first-line therapy now, unless there's some reason not to, like renal failure or extreme weight or extreme age. And frankly, they're all the same as one another. The only one that has a pretty consistent side effect is dabigatran, which tends to cause GI effects. But other than that, it's very personal, and one anticoagulant is as good as another as far as I'm concerned. So for him, he doesn't need any stroke prevention until he reaches the age of 65 or develops some other CHADS-VAS risk factor. So frankly, whether he's in AF or normal rhythm doesn't matter in terms of stroke risk. All he needs is a review at 65 to reassess that if he does have atrial fibrillation. The second priority for AF management is rate control. And if they have an average heart rate lower than 110 beats a minute, then they're safe. So the only reason to lower the heart rate beyond that is if they're symptomatic from palpitation. Now, the reason that rate control comes as the second priority is because if their heart rate is higher than 110, then that over many months or years can lead to a rate-related heart muscle problem, cardiomyopathy. But for patients that get AF episodes lasting a day, you can reassure them they're not going to get that. It's very unlikely. And you can argue that people run marathons or ultramarathons, the heart's designed to go fast for long periods of time, so it will tolerate AF for a day or a week or so. One of the ways of monitoring him would be to check on the ECG, and then if the rate looks okay, you may then want to confirm it on a 24-hour ECG. If the rate doesn't look okay on the ECG, then I'd get the rate down before you bother confirming it on the Holter, because otherwise you're wasting a Holter monitor. The best rate control is bisoprolol or a beta blocker because it has so many other benefits in terms of cardiovascular risk. But the problem with bisoprolol, particularly in younger patients, is it may be associated with side effects. So feel free to move them onto a calcium channel blocker at an early stage if they are not suiting the bisoprolol. And I find Adizem, diltiazem, gives the lowest rate of constipation. Verapamil tends to give quite high constipation. And you may end up having to use a combination of both in low doses if they're intolerant of high doses of one or the other. I'm going to now pass on to Boon, who's going to just talk a little bit about rhythm control. Boon, do you want me to advance the slides or do you want to share on your side?
Yeah, just stay on that slide and you advance. So in the rhythm control strategy, which is something to consider in your patients. So you asked the question about rate versus rhythm. The evidence is really conflicted at the moment as regards to prognostic benefit. The original trials in cardioversion versus antiarrhythmic drug trials showed no benefit or harm, so they were at equipoise. And a trial called Cabana, in which it was a multi-center trial with over 2,000 patients, was strictly negative on the intention to treat analysis, on the original pre-specified hypothesis, but on the intention to treat, when they spun the trial and looked at the patients who actually received the ablation, analyzed per treatment arm, it was positive for ablation. Very recently, in the New England Journal of Medicine, East, which is a German study, but truly led by the Germans, but a multi-center study of over 2,800 patients, was published, showing that the composite outcome for death, strokes, and hospitalizations were better, as you can see in this graph, for early rhythm control versus usual standard of care. And early rhythm control included early drugs in cardioversion or early ablation. And so this was the first trial that we've been waiting for a long time to show an outcome that was a hard endpoint outcome to show the benefits of early rhythm control. And it was a large trial with good numbers. So can we move on? Next slide. But in terms of the patient that you're seeing in front of you, what do you do with your patient? And I think first and foremost, we need to prevent strokes. And as Richard said, I also ignore Hasblads, can't remember it. I use Chad's Vasc, and I will anticoagulate whether or not they're in sinus rhythm in front of me if I know they've had a paroxysm or a clear diagnosis shown on the Apple Watch, for example, of atrial fibrillation. And the stroke prevention is at the very bare minimum, needs to be done for all patients. Rate control could be considered. Rhythm control is the question that we're talking about now. And really, rhythm control, until the publication of East last month in the New England Journal, was really a question of improving patients' symptoms. And one pragmatic strategy for patients who've just gone into atrial fibrillation, or very commonly, in my experience as well, patients who present but who do not know when they went into atrial fibrillation, we could offer them an initial cardioversion strategy. And this cardioversion does two things. One, it allows us as physicians to assess the likelihood of subsequent interventions succeeding, number one. But more importantly, it tells the patient how they truly feel in atrial fibrillation. That patient who's obese, has a bit of sleep apnea, diabetes, and hypertension may have many reasons for fatigue, many reasons for shortness of breath. But if you cardiovert them, and in the week after the cardioversion, when they maintain sinus rhythm, or even 2 days after, they can jump up and down and bound up and down stairs and have a new lease of life. You know, and they know, that actually symptomatically they improve so much that it is potentially worth pursuing an aggressive rhythm control strategy in them. The other flip side to a cardioversion is if I cardiovert a patient 3 times on the table in the cath lab and they fail after 5 or 10 seconds, or they are unable to cardiovert at all, then I know that patient's substrate has developed to the extent that it is very unlikely that whatever I do will restore normal rhythm. And so we might push that patient or accept more a status of persistent or permanent atrial fibrillation. The question you can ask the patient after a cardioversion is, how did you feel? Did you feel better or not? And in my experience, in my practice, if a patient doesn't feel one jot of difference after a cardioversion, even though they're maintaining sinus rhythm, I tend to not bother with a rhythm control strategy. I'd go for rate control because it's not going to make a difference to the symptom profile. risk factor reduction, as Richard said, is one of the key things now. Richard talked about the group from Adelaide who are trailblazing in this field of looking at the metabolic risk factors for promoting atrial fibrillation. And in one of their very interesting trials, a very aggressive weight loss program was as effective, if not more effective, as an AF ablation. And when you couple the two together, you get a synergistic effect to really enhance your outcomes and long-term maintenance of sinus rhythm. Of course, there are very many other benefits from weight loss, including hypertension and diabetes control, and all these confounding factors come into play to minimize the risk of atrial fibrillation. But in that patient in whom we decide to go for rhythm control, in addition to performing a catheter ablation strategy, which is the kind of final thing that we have to give them, we could, prior to that, go for antiarrhythmic drugs long term. So this would be things like sotalol or bisoprolol and flecainide, for example, for the patients with paroxysmal atrial fibrillation. And then obviously in those patients who have drug refractory symptoms, move on to a catheter ablation strategy. Let's move on. Next slide, Richard. So how do we follow him up? Next slide. Is it advancing?
You're going to have to make this up, Boon, because the slide's been wiped out.
The slide's been wiped out. So from the point of view of looking at your patient in the long term, what you'd have to do probably is to ensure that he knows how to take a pulse check. And a pulse check can be done by the patient, by yourself, or you can have a 3-monthly formal ECG and to continue to monitor his heart rhythm. As Richard said, for a rate control strategy, you want a pulse of something under 110 beats per minute. But for a rhythm control strategy, a pulse check with one of your AliveCore devices or a patient's or the Apple Watch Series 4 or 5 or a simple pulse check will do. Now, when I do an ablation, when Richard does an ablation, we tend to follow them up at between 6 weeks and 3 months with a formal 24-hour or 7-day event recorder to demonstrate to the patient that and to ourselves that the patient's rhythm is predominantly sinus. One of the peculiarities following ablation is that patients can often change their symptom profile from one of highly symptomatic atrial fibrillation to asymptomatic AF. And it's important to know with the monitoring whether, for example, they're getting nocturnal episodes of atrial fibrillation. I think it's good practice for them to have an annual follow-up in primary care. If all need to check on their weight, the diabetes, the hypertension, and a review at 65 years of age, because that is the magical age beyond which your CHA2DS2-VAS ticks up to 1. And so if you're female, and this is a question that I get asked very often, if you're female and you're born at age 1, you can't have a CHA2DS2-VAS of 1. So the female sex doesn't really count until you get to 65. And when you get 65, unfortunately, females score 2. And that, in my mind, mandates anticoagulation. At 64 years and 364 days, it's okay. So this is the importance of the review at 65 years. And I think I'll stop.
Thank you very much. That was all excellent talks, all highly pertinent to GPs, so thank you very much. We've had some great questions come in, so I think now is the time to move on to a few more of those. Boon, there have been a couple of questions about syncope. I saw you did have answers on the screen, but I think it would be useful to talk about it as well. One of them was about the very short prodromal symptoms before syncope and whether you consider those a red flag and how to manage that.
So it's a great question, very good question. It is a red flag because in my mind, and I always try and put myself in the position of the medical advisor at the DVLA, and this sometimes I disagree strongly, and sometimes I write a long worded letter to the DVLA because I disagree. But sometimes, I mean, I've grown not to bother so much nowadays. But if you were the medical advisor, or if you were crossing the street with your children on the school run, and you knew you just saw a patient who had short prodromal symptoms, would you be comfortable letting that patient drive? And the answer is no, because prodromal symptoms allow you to take evasive action in whatever setting that is. And if you're driving a car and you only have 2 seconds of prodrome, in my mind, that's not safe syncope, even if it was vasovagal syncope. So there's either something wrong with the physiology there, which is the autonomic nervous system is slightly abnormally configured, or much more likely is that patient is chronically volume depleted. The patient has no concept or no education on what triggers syncope, that a hot day, standing up for a long period, working long shifts, sleeping poorly, can be triggers for vasovagal syncope. And often just the education with the script that I taught you using the diagram from stopfainting.com is able to change that short prodromal symptom patient to a medium or long prodromal symptom. And that is all the difference between a red flag and an amber or green flag. And the moment I can make the patient change and lengthen the prodrome, in my mind, it becomes a safer patient. So the answer to the question is you need, unfortunately, to see them again. Or at Imperial, I am quite pro tilt table testing, which is a bit controversial, but I run one of the largest tilt table services in London, where we tilt about 800 patients a year at Imperial, both on the NHS and on the private side. And what we are really good at doing is we have nurses who are trained to explain to the patients. We may not have time, even I may not have time in a consult where we need to take the time to educate the patients about why they need to make those behavioral changes to improve the length of prodrome. But the tilt nurse will. And with the quality of data that they get to show the patient's blood pressure drop, they will often be able, almost always be able, to change that vasovagal patient with a short prodrome to a vasovagal patient with a long prodromal, making them less of a red flag.
That's very pragmatic. Thank you. That's very helpful. I'm going to stick with you, Boon, with another syncope question. So the question was, how severe does aortic stenosis have to be to cause syncope?
So the key thing about aortic stenosis is that the presentation of syncope with aortic stenosis is very different from vasovagal syncope. But in general, if you have moderate aortic stenosis with an impaired LV, then I think you can have syncope, or more commonly pre-syncope on exertion. If you have severe aortic stenosis, then you can have pre-syncope or syncope on exertion, but typically it is on exertion. And aortic stenosis also causes other symptoms apart from pre-syncope and syncope, including chest pain. And these are the key features in the history that you should be able to pick out to clearly distinguish that from vasovagal syncope.
Okay, again, very clear, thank you. Moving on, Richard, I think back to you, another question about palpitations. It was asking patients who potentially more drug and alcohol use in young people, potentially increasing presentations with palpitations. Also, of course, anxiety now with the more mental health problems in young people. How to negotiate this, particularly trying to avoid the pitfalls of overdiagnosis.
Yeah, I mean, for GPs, it's an absolute nightmare, because, of course, the luxury that I have is the time to spend with the patient, talking through the mechanism of their symptoms, why they may be getting them, and how they might negotiate around them. I mean, one of the problems is it takes me 20 or 30 minutes to really go through that in detail, but that 20 or 30 minutes will often save me several clinic visits and unnecessary investigations. But of course, GPs only have 10 minutes in order to deliver that. So God knows how you get around that. I think that underneath it all, patients know in their heart of hearts what the healthy things to do are. And the key bits to tell them or explain to them in the story is, if it doesn't sustain for more than a few seconds, if they have not had any worrying symptoms like blackout, then they do not have a pathological rhythm. And this can all be explained by them maybe not taking care of themselves. And trying to spin it into a positive way, that here's the beginning of your new life. This benign problem actually could save your life by changing all of your other cardiovascular risks, by losing weight, getting fit, cutting down the cocaine and ecstasy or whatever other medication you may be taking. It's a very positive thing. And that's the way I try to get them to look at it, but it's really challenging.
Okay, that's very helpful. And I think sticking actually with that point, so another question came in regarding you're saying that caffeine wasn't a big problem, because I think, you know, one of my GP colleagues is highlighting how this really has been a mantra for GPs for a very long time, saying that people with palpitations should be cutting down on their caffeine intake. So I'd be interested to hear more about that, because that really does go against the sort of bread and butter GP advice that we've been giving for a long time.
Yeah, well, there's one study, one meta-analysis that included nearly 250,000 patients, and what they showed in that study is that the greater your caffeine intake, the less likely that you were to get atrial fibrillation. Now, it's likely that this is just a statistical anomaly, but what it really highlights is that there's absolutely no evidence that caffeine has an important factor to play in AF. The key thing is weight. I would say that's my number one, and then the number two is alcohol.
Can I also just drop in here, and I don't know whether Richard will agree, but some of the common triggers that I've found, and I'm biased because I like the autonomic nervous system a lot. I studied that in my PhD, and one of the key triggers that I find with particularly nocturnal AF is that you can often consider that the alcohol the night before could be a trigger for the nocturnal AF. And that's potentially where the alcohol thing comes from. But I often find that the transition between a heightened adrenaline state and an emerging vagal state, for example, during sleep, but more commonly, not during exercise. So your patients may get AF 4 or 5 hours after a particularly intense workout. And this is quite an anecdotal experience, but it's when you express the sympathetic nervous system very heavily. And this could also occur after a very long, stressful day. And then you relax too much, for example, by taking alcohol in a large meal to have a postprandial state of highly expressed vagus. That's when the nocturnal atrial fibrillation will occur. And a very large European heart study looking at triggers of atrial fibrillation found that at least in a third, if not a half of the patients who have atrial fibrillation, the triggers are autonomically driven. That means lack of sleep, too much exercise, alcohol, and stress. So I think if you consider sleep apnea an extreme form of stress as well, that's where the link comes in. There's a very, very strong emerging evidence that sleep apnea is one of the primary drivers with nocturnal awakenings that trigger atrial fibrillation. And so until you treat sleep apnea, it's hardly any point doing an ablation procedure. So I always screen for sleep apnea and make sure the patients are treated. And it's a very different practice from 8 to 10 years ago, where we didn't see this emerging evidence from the Australian group.
Okay, that's great, thank you. Moving on, some more questions. There's a question about whether after a patient has had an ablation or cardioversion, do we still need to anticoagulate? And I saw you had answered that already, Boon, but I don't know if it would be a good one to again discuss.
Yeah, so the decision to anticoagulate doesn't depend on whether you're in sinus rhythm or atrial fibrillation. As Richard said, you can get strokes even in sinus rhythm. So the decision is purely based on the CHA2DS2-VASc score. And so if your CHA2DS2-VASc is less than 1, then we would typically stop the anticoagulation after 4 weeks. when we're doing a cardioversion, if they are maintaining sinus rhythm. And if the CHA2DS2-VAS is greater than 1, we commit them to lifelong anticoagulation, because there's no guarantee that they will remain in sinus rhythm. They could have episodes of AF recur, and importantly, not know that it's recurring.
Okay, thank you. And then another question regarding asthma and beta blockers. This again is always a quandary in general practice. What are your thoughts regarding safety of prescribing beta blockers in patients with asthma?
Is that for me or for Boon?
Boon has actually, I think, commented already, so perhaps Boon, if you'd like to go first, and then Richard, if you had anything to add, that might be good.
So my kind of pragmatic line is, if they're not taking regular bronchodilator therapy, I will try a small dose of a beta blocker. I don't mind bisoprolol 1.25 as a trial. And if they are taking bronchodilator therapy, then I'm more cautious.
I think that's my respiratory colleagues tell me, that the beta blocker makes the bronchodilators less effective. So it doesn't necessarily cause asthma, it makes the bronchodilators ineffective, which is why Boon's saying if they're taking bronchodilators, maybe it's best to avoid a beta blocker, but you'd be amazed how many people can get away with a small dose.
Yeah, absolutely. Okay, another question. This is a great question, I think, about persistent sinus tachycardia. Again, this is something which we see quite a lot in general practice, and I think we see more and more potentially because of patients wearing Fitbits and being more likely to monitor their own natural rhythms. But when do you think we should be investigating a persistent sinus tachycardia without any red flags? Perhaps this is initially directed for Richard.
Persistent tachycardia is not an uncommon phenomenon. It can be post-viral. So in the COVID era, we may see more of these patients. Inappropriate sinus tachycardia is basically where the heart becomes more sensitive to adrenaline, and so they'll get a greater rate response to pretty minimal stimuli than you would normally expect. It has no prognostic significance. So obviously you want to look for secondary causes like thyroid or a knife sticking out of their back. But other than that, it is a completely benign thing, and it's very important that they don't get drawn into investigation and treatment and end up having treatments that are actually far worse and far more unpleasant than the sinus tachycardia itself. So getting early reassurance is really key. So as I said before, if it accelerates and decelerates, it's the heart responding to something. It's sinus tachycardia. If it steps up suddenly and drops down suddenly, that's the time it's worth investigating, because that may be a pathological arrhythmia.
Okay, that's very helpful. Thank you.
So can I just add to that comment? In the post-COVID era, I'm seeing a lot of patients with this condition as well, inappropriate sinus tachycardia. And with my syncope hat on, I often lie them and stand them up. And if I'm finding a slight blood pressure reduction, again, looking at the mechanism that we talked about with the blood pooling, if that leads to a slight decrease in blood pressure and an increase in adrenergic expression, then they are bound to get an increase in heart rate. So if that increase goes by more than 20 beats a minute, then I think that is not pathological, but an indication of a either deconditioned or volume depleted state. And one of the reassuring things you can say to them is that this is not pathological. Look, it goes up when you stand up, and when you lie down, it's much better. And therefore you need to drink more and salt more, particularly if the patient is or has been lying down for a long time. We were meant to be upright as bipedal mammals. And when we're lying down for a long time, and actually in some of the early studies of POTS, the physiology was gained from astronauts in space. And astronauts in an anti-gravity environment lose body volume, right? So if astronauts spend 60 days in space and comes back to Earth, nearly all of them will have inappropriate sinus tachycardia, or POTS, postural orthostatic tachycardia syndrome. And imagine your long COVID patient who's had 6 weeks of COVID lying on a bed. That's one explanation why they might feel the pounding heart rate, some with chest pain associated with the tachycardia through the very mechanism that I explained on Stop Fainting, that website diagram. So I think I'm seeing a lot of this now in my syncope clinic, and it's one thing that you should be able to reassure them by doing a simple lying and standing test.
Okay, that's great. And actually then another twin for that, a question coming in regarding sinus bradycardia, and again being picked up more now with Fitbits. What would you advise patients who come in saying that their Fitbit says that they've got persistent sinus bradycardia?
Let me answer this. This drives me mad. So there's only one prognostic bradycardia, and that's complete heart block. Every other bradycardia is annoying and causes symptoms, and we put pacemakers in to alleviate those symptoms, but it is not prognostic. So slow heart rates are irrelevant unless they are causing symptoms. And particularly at night when you're asleep, your heart rate will drop to 20 or 30 if you're young and fit, or even if you're not. So as long as it's not causing symptoms, bradycardias can be ignored unless it's complete heart block. Am I being too dogmatic here, Boon, or do you agree?
Yeah, I would agree with that. I just not reviewed, but I was giving a lecture on pacing guidelines, and actually the guidelines are there to guide us. It's not mandated action, but symptomatic. If a patient is dizzy, I know Richard talks about prognostic, which means death, but if a patient is dizzy with bradycardia, then my view is that we may need to try and understand why they're dizzy and in what context they're dizzy. Vasovagal syncope can also cause a bradycardia. That's something that can be treated easily, but somebody who has intermittent 2-to-1 heart block or complete heart block will need further diagnosis, investigations, and treatment. So asymptomatic bradycardia, I fully agree with Richard. Ignore. Asymptomatic, ignore.
Okay, thank you. Then a couple of case queries. I can see a young patient who loves weightlifting, who describes syncope but with a prodrome, and a fixed maximum heart rate of 110 beats per minute, even during exercise. What are your thoughts about the implications of that? Richard's already done a short response, but perhaps to expand.
This sounds like a tricky customer in my clinic. So I've got a weightlifter who doesn't want to stop weightlifting, although has pretty short prodrome because it's her passion and life, and it's very challenging. Weightlifting is a very extreme Valsalva. For those of you who haven't seen syncope, Google or YouTube the German mess trick. The German mess trick are a bunch of crazy German students who essentially do a very heavy Valsalva in a weightlifting-like maneuver, and they all have convulsive syncope. And so it's possible, if you're a weightlifter, that you are always predisposing yourself with the correct physiological shifts in blood volume to provoke a very severe kind of syncope. So I think an occupational hazard, weightlifting is an occupational hazard if you are susceptible to vasovagal syncope. I can't really explain the tachycardia aspect of weightlifting. When the weightlifter comes back and lies down in bed and is relaxing, they should be fit. And so this persistent tachycardia is something that I cannot explain.
Thank you. And again, a couple more more specific case questions. Do you think all cases of cryptogenic stroke should have a long-term loop recorder implanted? Will it help with the management?
Well, I'll pick that one up. So the NICE guidance has recently looked at this. and I think have made some rather silly recommendations that loop recorders should be used universally. I think it's a case-by-case basis. You could argue that if someone's had a cryptogenic stroke, there's no other cause for it, and the patient's got a high CHA2DS2-VASc score. If you're going to put them on aspirin, why not put them on a NOAC and protect them from an embolic stroke from AF? It's a loop recorder is a pretty expensive investigation to prove what you're probably suspecting will happen sooner or later anyway, i.e. that they will be shown to have atrial fibrillation. Nevertheless, I have used it in patients where there's doubt. It's an incredibly useful investigation. It lasts for 3 years. It has a pretty high rate of pickup of AF. And for those patients where there's no other obvious cause, it can convince them that taking a stroke prevention medication would be worthwhile doing. I must say that if I personally had a cryptogenic stroke and there was no other underlying cause that I could find for it, I'd probably take a NOAC.
Well, at a risk of being controversial against Richard, which I dare not do normally, I was asked because I'm the lead for the Link team, and at Imperial, where we have a strong stroke unit, the neurologists are very keen that we support their cryptogenic stroke Link implants. They have an arbitrary cutoff age, which favors the younger patients having this approach rather than all comers. So they're not applying this for everyone. But on one of the trials, if I recollect properly, they adopted this very strategy where they said, let's not bother with the ILR, let's give everyone a NOAC. And there was an excess bleeding risk in that arm, which halted the trial. Now, I have to read the trial again because it's been some time, but I think, as Richard said, I would agree, case-by-case basis. You have to make the argument on a case-by-case basis, and ideally in collaboration with a sensible neurologist.
Now, here you see a perfect example of an old professor giving opinion being deflated by someone with actual data and evidence. I stand back and...
I'm so sorry, Richard, so sorry.
Right, moving on with an excellent question that has come in regarding new onset AF for a patient who's hemodynamically stable, rate not too high, and no signs of a reversible cause. Would you always refer these patients urgently for consideration of rhythm control, or do you think there are circumstances that those patients can and should be managed in primary care? Again, I think this is a really pertinent question. Perhaps to Richard to start, and then Boon to rebut with the evidence.
Oh, it's getting a bit catty now. So the first step is your first priority is stroke prevention. Can you initiate stroke prevention in primary care? Well, of course, yes, you can. You can do a blood test to assess renal function and check that they can take a NOAC and just initiate it. The second step is rate control. Well, GPs prescribe beta blockers all the time. There's no reason why you shouldn't prescribe a beta blocker and slow their heart rate down. And it's perfectly reasonable to do that primary care and bring them back maybe for early appointments just to assess the impact of the beta blocker so you can titrate it up. But I would do that in a clinic setting all the time. I think that's completely reasonable. So start them on 2.5 of beta blocker of bisoprolol, bring them back a few days later or a week later and just check their heart rate and increase it again. And then at the end of that, you can assess, are they getting symptoms or not once the rate is well controlled? And only then would I think, do I need to refer them for rhythm control based on their symptoms? But I think that Nikki Fowler's question is a really good one, and I think you can do a hell of a lot in primary care.
I like that answer a lot, and that's exactly what I would do. And if the patient, so the question is very specific, symptomatic new onset atrial fibrillation, and just thinking about the the risk factors for success. Okay, if we're going to pursue a rhythm control strategy, which means we want to get them back to normal rhythm, there is a time window in which the rhythm control strategy will be more effective. And you might not know this, but the factors we look at when we consider rhythm control would be the left atrial size, for example, duration of atrial fibrillation, presence of other risk factors, and actually looking at the patient. If they're very frail and will not tolerate general anesthetic or have other issues that make any kind of rhythm control strategy quite dangerous, we are pushed one way in our decision making. But if they're young and actually have a lot to gain from being less symptomatic, because you know they're going to exercise and they're going to take their heart rates right up when they exercise and be limited by atrial fibrillation, then in those group of patients on a case-by-case basis, I would suggest an early referral to an electrophysiologist.
But it's weeks and months, not years. So it's very reasonable to spend a couple of weeks getting the rate under control in primary care. You've got plenty of time to work out whether they do need rhythm control, as Boon says. What you don't want to do is bring them back for a 6-month follow-up, because then the horse has bolted. So doing it at an early stage with rapid follow-up is perfectly reasonable.
Okay, thank you. And then there's a question about what choice of DOAC you would use for patients who are obese. Perhaps Boon, perhaps you'd like to answer that one first.
All DOACs are fine. All DOACs are fine.
Right.
If you Google the North Central London prescribing guidelines, they have a really good published guideline for DOACs and a flow chart of when you can and can't use them. And I think it's a very nice guideline. So I'd Google that, and that's a really nice way of knowing what you can give and what dose.
Thank you.
It's 16 page document, Richard.
There's a flow chart in it that helps you, a decision guiding thing. There's a flow chart that I find quite helpful.
Okay. I'll try and share it on the chat now. I've just downloaded it.
Thank you. And then I think actually this goes back to our previous question. So when AF is, and again, this is very typical general practice, when AF is an incidental finding in elderly patients after we have initiated rate control and DOAC is appropriate, should we be referring these patients to secondary care? Is there any benefit for them? Perhaps Richard, you could start with this while Boon is sending the link.
Sorry, so Melanie, the question was, is there any benefit to sending to secondary care in the elderly? Is that right? Yeah.
Well, I think when it's an incidental finding and they're not symptomatic, and so you don't know how long it's been there for, is there any benefit for those patients?
No, frankly. You know, the primary care are better at looking after them than we are.
Yeah, I think that's really helpful. Thank you. We have a few more questions coming in. Okay, how does hypothyroidism cause atrial fibrillation?
It shortens the atrial refractory period and makes the atria more likely to develop atrial fibrillation. So it's basically an electrophysiological effect of the thyroxine that makes the atrial electrical activation become less uniform, and therefore the potential for developing macro re-entry. And if you get rid of the hypothyroidism, often the AF will resolve.
Thank you very much. And then another question that came in regarding going back to palpitations with recreational drugs. Are there any particular recreational drugs that you are concerned about, or sort of red flags that make you worry about patients who then present with palpitations?
Is this the sort of question where they said, I think I may have a friend that wants to take recreational drugs, but wants to know which ones are safe? I don't know is the short answer. I don't think there's enough evidence to tell us one way or the other. I mean, clearly, things that stimulate, like cocaine and amphetamines, are likely to cause cardiovascular problems. We know that cocaine is associated with premature coronary disease. For AF itself, it's not a signal I'm seeing a lot of in my clinical practice, that patients are presenting with AF because of taking recreational drugs, but then they may not be very honest with me about that.
Okay, thank you. And the question just came in regarding, the question is, how will you treat asymptomatic sustained VT picked up incidentally in a patient with AF?
It's a surprisingly common finding, to be honest, and typically seen in patients who are inadequately rate controlled. The VT spurts that you see are typically in the context of fairly rapidly conducted atrial fibrillation. So I would treat it with increasing the beta blocker dose. Diagnostically, I would want to know whether or not the patient has a trigger for VT. And whenever you have high heart rates that are associated with VT, you might think of ischemia driven by tachycardia, right? And that's the kind of whole idea of an exercise test, driving cardiac inotropy, chronotropy, driving ischemia and getting ST segment shift. So VT as a sign of ischemia is something to look out for. And then where we go from there is risk factor management, hypertension, diabetes, family history, smoking, cholesterol. These kind of things need to be considered. And if you think the patient's at high risk of having ischemic heart disease, then you might then start off with an echo, for example, or refer onwards. So that's where I would go. But the first instance is beta blocker, repeat the Holter, perhaps, and reassure yourself that the AF is more rate controlled and there's no further VT.
Okay, thank you. And then there was a question a little earlier on, actually, again, going back to beta blockers, asking the patient, for asthmatic patients, why would we not consider using ivermectin instead of a beta blocker?
So ivermectin is a very selective sinoatrial node IF current blocker. So it's a blocker of potassium channels, which are only present in two areas in the body. One is the sinoatrial node, the other is the retinal cells. So you might get this phosphines or flashes of meteors that is one of the side effects of ivermectin, which is normal. But you wouldn't use it for AF because it doesn't impact the AV node. In atrial fibrillation, the arrhythmia is due to multiple circuits within the right and left atrium. And the rapidly conducted atrial fibrillation goes through the AV node. Ivermectin doesn't target the AV node, it targets the sinoatrial node. So it has some use, very weak evidence, in this condition called inappropriate sinus tachycardia, which is the thing we already covered.
Okay, that's very helpful, thank you. And just another couple more questions coming in, and then I think we're going to have to wrap it up. But we have a question, I think, again for Boon regarding syncope. Is the posture with syncope important? So is it you're more concerned if a patient has syncope when they're sitting down rather than when they're standing up?
Yeah, so until about 5 years ago, it was not considered an important question by the DVLA, but now the DVLA make it very, very clear that if you have seated syncope, then driving is a problem as opposed to standing syncope. So in my books, physiologically, it doesn't make sense because you can be seated, but you can be very naughty. You haven't drunk, you're on a hot day, you're in a sauna seated. What does it mean when you have syncope in the sauna if you're seated? It doesn't mean you're high risk than somebody who's standing with a very short prodrome. So in my mind, I take it back to the physiology, and the infuriating discussions I've had with DVLA has been on this very issue, that a patient who's had seated syncope has been banned for driving for some time. And it's because they were unwell with diarrhea and vomiting and all this kind of other factors. So I think for the purposes of DVLA and risk stratification, red flags, maybe, if you have to be simplistic about it. But if you think about the real risk factors here, it's really short prodrome, right? which is the thing that can cause injury or a car crash. And short prodrome, when you are as well behaved as you can be with hydration, salt, keeping cool in an air condition, is a red flag.
Okay, and then a comment saying, how is it possible to have chronic ventricular tachycardia, which I was also thinking, but I think we can move on to the next question. So I think this is the last question, and then we are going to wrap it up. What happens at a pacemaker check, and what should we do over the next 6 months if this cannot or doesn't happen for a patient? Again, I guess very timely with COVID happening and not sure what's going to happen regarding restriction of secondary care access.
So I was going to say pacemakers like Boeing airplanes seldom go wrong, have a rate of failure that's extremely low. Your pacemaker indication, i.e. your patient who needs a pacemaker for complete heart block, for example, without which they would be collapsing, it will become very evident if the pacemaker is not working, because they will be collapsing. In all other scenarios, don't worry about it. The other thing to say is at Welbeck and in most NHS trusts now, we actually give out a very handy device that looks very futuristic. It's like a Google AirPod or a sexy rounded Alexa, which is about that big. The patient is given that. It's put by the, oh my God, my Alexa just came on. The patient is given that to put by their bedside, and by the bedside with a SIM card, every night when they go to sleep, the pacemaker transmits data to the central hub. And if the hub, whether it's your NHS hub or at Welbeck, detects any abnormality, for example, failure to capture or any changes in parameters, then the implanting physician will be alerted. So post-COVID, most trusts, not all, but most trusts should be providing what we call remote monitoring to all the patients with pacemakers.
Okay, that's great. Thank you. And many thanks to everybody who sent in those questions. That was a fantastic range of really pertinent and interesting questions. Many thanks to Richard and to Boon. That was fantastic, educational, entertaining. Many thanks to Wearable for all her behind the scenes tech support here. And that was a really excellent session. I don't know if Richard or Boon has any final words. Otherwise, I think we will wrap this up. Many thanks to everyone for attending.
Thanks very much, Melanie, for really sharing this in a brilliant fashion. And I would echo, it's been real fun interacting with all the primary care physicians on the chat and in the questions. That's made it worth doing for me.
Thank you all for attending. Thank you so much, Melanie and Rupal, for organizing and for chairing it. Much appreciated.